So, uh, good morning, everybody. I invite you to this to be a part of this instruction course. I know it's a first day, first show kind of thing, and we have less audience, but I think we need to stick to the time schedule. So we go accordingly. So we begin our instruction course, and I would invite first Dr. Ritika Sachdev to come up on the stage and show us her presentations. And she's an eminent surgeon, and she will be talking to us about the femtocataract, the rupture, and the management.
Thank you, Dr. Priya. It's always a great privilege to be part of your course. I'll be starting with, can you just connect? It's a video, so I'll just be taking you through a video which basically is about managing the vitreous when it surfaces in femtocataract. Now, femtocataract has some unique points. You know that the laser does the capsulotomy. So when the capsulotomy is fashioned by the So when the capsulotomy is fashioned by the laser, you often have areas of micro-adhesions. It is very important to recognize these areas, though with the newer platforms like the Catalyst and the SoftFit PI, these adhesions are now less commonly seen. So I'll just be starting with a docking procedure. This is with a liquid optic interface of the Catalyst system. You see the overlay of the treatment pattern is seen. The capsulotomy is completed within a few seconds. Then the nucleotomy begins. This is a white cataract, and the reason I'm demonstrating a white cataract is basically because when the fluid comes out from the nucleus, it's moving back. Sorry. ये loop में play कर रहा है वहाँ पे. It's getting stuck. So you see here that the fluid has leaked out, and therefore there is an area which is a skip area. This means that though the capsulotomy has been cut, there is an area which is uncut. At this point, it is important to note you must stain with trypan blue, and when you're pulling the rexus, don't pull it centrifugally. You must make sure that your pull is centripetal so that the rexus is complete, and then you go on with the nucleotomy. This step is important because it is the capsular tag which most commonly lends itself to extension and causes the PCR in femtocataract. The rest of the procedure goes on like a normal cataract. Now I'll be showing you a case of posterior polar cataract which has been taken up on the femto platform. What is beautiful about the platform is that you're able to image the defect. So you see here, when you zoom in into the OCT, you can see there is an underlying defect. There is a discontinuity in the posterior capsule, and this really is a pre-operative indicator that you will most likely face an intraoperative PCR. At this point, you must increase the posterior offset, which basically means that you have to have a larger epinuclear and an uncut portion to prevent the nucleotomy going too close to the, I don't know why it's just moving back on its own. ये वीडियो वापस जा रहा है. So this is how the case looks after the femto treatment has been done. You see here the sextants are there. What you see on the other side is the intraoperative OCT. The intraoperative OCT actually shows you a little bit of a epinuclear dropping because there is a discontinuity in the posterior capsule. This is the intraoperative OCT. Because the vitreous is formed, if you remove the nucleus without much manipulation, you're able to manage without a PCR. But note here that at the last point, the PCR now is evident. What was most important was that, I'll just go back into this point, that as we are doing the irrigation aspiration, we reach the area of the PCR in the end. We do not withdraw the instrumentation without putting in viscoelastic to tamponade. You see here on the OCT that there is a formed vitreous, though there is a mild herniation from the area of the PCR. What has been done here is a single piece IOL has been placed inside the bag. With such a large slit like PCR, that may not be a great idea. What happens here is, you can see when we hydrate, there is still some vitreous that has surfaced. And you see that the lens is not stable, it is tilting. So what do we do now? We are going to try and position this lens back into the anterior chamber over the iris and then remove this lens. Why it is important to remove this lens is, as you can see, this is a single piece IOL. It is not mandated to put in a single piece IOL in the sulcus, and that is where the lens may need to be positioned in the event of a PCR. A single piece IOL has thick, bulky, square-edged haptics which will rub across the posterior surface of the iris and cause pigment dispersion and lend itself to an inflamed eye. So what you see here, I'm extending the incision slightly, giving a cut halfway through the IOL, engaging the IOL into the incision through this area of cut. This allows you to maneuver the IOL out through a smaller incision by simply cartwheeling it out. At this point, you have to place now an IOL in the sulcus. A vitrectomy is done. You have to make sure that the capsulorhexis is intact. The pupil has come down on us. Do not hesitate to put in iris retractors for better visualization. So once we've put in the iris retractors, we see that the femto has fashioned a beautiful CCC, and over which a 3-piece IOL is now implanted. A 3-piece IOL is the ideal IOL for implantation in the sulcus. Once a 3-piece IOL is implanted, we're just making sure that we've cleared the vitreous earlier, just making sure that the area is clear of vitreous, and removing the iris retractors. The pupil being regular is an indicator that the vitreous is absent from the anterior chamber. A small suture is placed, and this is how the patient looks like on day 1. I'll now be just showing another case of posterior polar cataract. This is on the LensX platform, which is by Alcon. The treatment of the femtocataract is similar. You have the capsulotomy being fashioned. On the other side, you see the OCT, wherein you see the nucleus. This is the nucleotomy coming in. You can choose various patterns. The earlier pattern was that of a division into sextants. This pattern is more into smaller cubes, the matrix pattern. The incision and the arcuate to correct astigmatism are then fashioned. Now this is a posterior polar cataract. There is some amount of pneumodissection that has already been done due to the femtofiring, but once we remove 2 pieces of the emulsify the nucleus, you see here the red reflex has become very visible and the nucleus is pointing posteriorly. What do we do at this point? We have a posterior capsular end that has surfaced, and we have non-emulsified nucleus, nearly half of it still in the bag. So this is a technique that we will be following here. You see that we are going to try and pull this nucleus piece into the anterior chamber. You can use posterior levitation, or you can use a blunt instrument which has been put in through a side port to then guide this half of the heminucleus into the anterior chamber. This is sometimes tricky when you have a large rent, but you have to make sure. And what makes it actually trickier in a femtocataract, this has been pre-treated. So it cheese wires. If you're doing it in a normal phaco case, then it actually comes out as a single piece. Now once you have this heminucleus over the iris, we will now go in with the technique that Dr. Amar Agarwal has popularized, which is the IOL scaffold. A 3-piece IOL has to be implanted in the sulcus anyway. So this is a premature implantation of the 3-piece IOL. The IOL is implanted in a way that that one haptic is over the iris, and ideally one haptic should be outside from the wound, so that you're able to retrieve the IOL if required. Now this IOL gives you an artificial separation wherein the nucleus will not fall back into the vitreous. So with this IOL behind the nucleus, the phaco is now used to emulsify the heminucleus. Please note this is a technique which is very safe for soft nuclei. In harder nuclei, you must make sure that the endothelium is protected very well with viscodispersive viscoelastics. So once this 3-piece IOL is safely now guided into the sulcus, because you do the clearance of the cortex, and now the same IOL that has served as your scaffold is implanted into the sulcus. The AC is clear of vitreous, and this is how the patient looks like at the end of the surgery.
23 gauge micro
I'll
incision
just stop here.
trocar
Thank you
cannula
for your
system
attention.
forms the backbone of this instruction course.
Thank you,
It is
Dr.
imperative
Ritika,
to
for your
understand its component
presentation.
and
It was
usage to
great.
fully
I would now
utilize the
invite Dr.
tricks shown
Partha
in this.
Biswas to please come up, and he'll be talking to us about the PCR and posterior axis. Coming up to Dr. Ritika, I think the videos were excellent. They were great teaching points, and that you should avoid putting a one piece into the sulcus, and the way she showed the femtocataract and the difficulty with levitating the nucleus in the femtocataract. So I think these were all very clinical points, and which surgeons they usually come across. And please do take a note of all these things, because even if you get one or two tips which really help you out in the procedure, like, it's worth being here. Thank you, Dr. Ritika.
Much. Good morning to every one of you who is present here in this hall, and thanks to Dr. Priya, Dr. Lalit Verma sir, for giving us this opportunity to be here in Gurugram early this morning today. So I just remembered that in my first day of residency, when I went to my HOD and he was in the theatre, and one of my colleagues, a fellow resident, he asked my HOD very, very aptly, he wanted to learn. So he said that, sir, you're doing a cataract surgery. What happens if you do if there's a PCR? So that was his first question in a residency program. So sir looked up and said, "Shubh shubh bolo." The next day, again, he wanted to show off his guts, and he said that, "Sir, I have learned everything about PCR, and I just want to know that if there's a nucleus drop, what to do." Sir said, "Just get out of this room." So this is what happens, and early morning today, so we start with shubh shubh bolo. So, so converting, so the only shubh that I can think of in a PCR is converting PCR into a PCC. If we can make a PCR into a posterior capsular rhexis, the shubh has happened. So let's look at this. जब शुभ हो ही नहीं सकता है, there is a large PCR, a nucleus in the cortex, and can someone come and just put the sound cord, please? So the nucleus is there in the anterior chamber, and what needs to be done, and Ritika showed the IOL scaffold, which is an excellent technique, but also if we can separate out the nucleus from the anterior vitreous that is very much there by dispersive viscoelastic, placing the whole layer of dispersive viscoelastic, and then removing the nucleus by very gentle phacoemulsification, replenishing the viscoelastic time and again till it is very much there, and you're seeing that the nucleus is not going down. The anterior vitrectomy is a very important step. The anterior vitrectomy has to be done well, and the vitrector has to come in from the side port and not from the main port. Therefore, you have a closed technique and an anterior vitrectomy to be done. The intraocular lens, in this case, we placed it over the sulcus, and after placing it over the sulcus, you can capture it in the anterior capsule. And once captured in the anterior capsule, this is a very, very stable situation which stays on and on. And of course, there's vitreous in the anterior chamber, and whatever vitreous is there has to be removed by good anterior vitrectomy assisted by tricot. Let's look at the next situation, and when PCC is possible. So this is a very, very important solution, and here we are, and we have completed the removal of the cortex, and then as we remove, we suddenly find that there is a small PCR, and this PCR is central. When such a thing happens, and possibly it was just removing that irrigation aspiration cannula that it happened. So by this side port, putting in dispersive viscoelastic, having a nice inflated anterior chamber, and then going with the microrhexis forceps to carve out a very nice and a neat posterior capsular rhexis. This is an ideal situation. If we can achieve this, the Rome is won. But it's not achievable in every case, and therefore we have to understand that every case has to depend upon its merit. So this is a single piece lens which can go into the bag. This bag is a stable bag. It will not move out, and the posterior capsule is well taken care of. So it's also important to remember that when we put in the tricot, the triamcinolone, this should be just enough to be in the anterior chamber, should not go into the vitreous cavity. Otherwise, you have a huge blob of triamcinolone in the vitreous cavity, which best be avoided. Now let's look at this situation, and you can see that I've had a real tough time, and we've put in 5 hooks here, and these 5 hooks, and I've had a PCR. Now with this PCR, trying to take off posterior capsular rhexis, and once the posterior capsular rhexis is done, then what, as we can see, that the iris is popping out and there's vitreous very much in the anterior chamber. But with this amount of vitreous in the anterior chamber, a good anterior vitrectomy needs to be done. And if a good anterior vitrectomy has been done, then the vitreous traction on the base of the vitreous is relieved. Why is it important that we should do a good vitrectomy? It's to relieve the vitreous traction on the vitreous base, number one. This was a small pupil. If someone cannot see through the indirect in the periphery of the retina, this has to be taken up and has to be seen very well in the post-operative time. The post-operative recovery is usually a little late. There can be a lot of corneal edema, but these cases, vitreoretina evaluation is 100% must. So once that is done, then the next part is easier, and we can place the intraocular lens in the bag, tricot assisted vitrectomy of the anterior chamber, and you can see that there is quite a large amount of vitreous in the anterior chamber. So again, if it is a small pupil, the pupil has to be well out of the way. If it is not well out of the way, visualization of the anterior capsular rhexis, visualization of the triamcinolone becomes difficult. So in all these cases, if the patient is under topical and you're not comfortable under topical, you can give a little bit of peribulbar injection, and that has the patient well controlled for a longer period of surgery. So let's look at this case in which we have a PCR with the nucleus and cortex, but the nucleus and the cortex is not much. So once I have detected the amount of PCR, so what I'm doing is placing this dispersive viscoelastic, and then we still are able to retrieve that posterior capsular rupture, and I can make a PCC out of this posterior capsular rupture. We do have a fragment of the nucleus, and we do have a little bit of cortex over there. So placing in and removing the cortex very gently, trying to see that the vitreous is not disturbed. If the vitreous comes into the anterior chamber, this is the time that you have to do a vitrectomy. If there's vitreous into the anterior chamber, vitrectomy is a must. If vitreous is not there in the anterior chamber, then you can remove the amount of cortex by the bimanual as well. So you can see that there is still a fragment of the nucleus there, but I wanted to place the single piece intraocular lens in the bag, and therefore went ahead with this part of the procedure, placing it in the bag and placing it so that this forms a scaffold for that nucleus fragment that is there, and it's a small fragment which we can take off. So again, we have the benefit of a posterior capsule which is quite stable, and once removal of this little fragment is done, then the vitrectomy needs to be done, and once there is no vitreous in the anterior chamber, we can get ahead with it. So I come to the last two small clips of the videos, and this is if there is a posterior capsular rupture, and this was a PPC. Can I just take 2 minutes, Priya? 2 minutes. So this is a posterior capsular rupture, and you can see that this posterior capsular rupture is through and through transverse. And I would like to tell you that this is a very important technique that can be done, not in all cases, but in some cases definitely. In this case, I'm going to stop here and think, can we place a single piece lens in that ruptured capsule which is torn right from side to side? Yes, we can, with a little bit of technique, a little bit of expertise. Now just watch what we are trying to do. So we have the anterior capsule well and round. The posterior capsule has ruptured transversely. What we are trying to do is, the first step is placing dispersive viscoelastic between the ruptured posterior capsule and the anterior capsular rim. So the space is made out. So once the space is made out, we land the single piece lens, the haptic of the first haptic is landed on the iris. And once it lands on the iris, we let it unfold. Once unfolded, then this haptic is just very gently twirled in, and it acts as a fulcrum, and it goes in between that space between the anterior capsule and the ruptured posterior capsule. Similarly, the trailing haptic is also done the same way. That space has to be maintained. If we are not able to maintain that space, then the haptic is going to go into the anterior vitreous. It is a little tricky, but if you have a very well-formed anterior chamber, if everything is stable, this is possible. And of course, removal of any vitreous from the wound or from the anterior chamber is a must. The last of my videos, and here again, this situation is one that it's a PPC, and again, I have had a posterior capsular rupture through and through, but this time it is different. So here it is a longitudinal rupture, and one part of the rupture is a little larger, one segment is a little larger, the other segment is a little smaller. So in this case, can we place a single piece lens in the bag? You can see that this part, the left part, this part is a small part, and here I'm putting that blob of dispersive viscoelastic to separate the anterior capsule from the ruptured posterior capsule. Again, landing the single piece lens over the capsule, in fact over the iris, letting it unfold. Again, placing viscoelastic so that we have a stable chamber, and then under direct visualization, we are placing this haptic in between the torn posterior capsule and the anterior capsular rim. We have to be 100% sure. It has to go a test. You have to see that it is well placed, and once it is visualized, it is well placed and it is stable, then only this lens can stay, and it can stay forever. Of course, we have to do a follow-up, and follow-up is not only for the anterior segment but also for the posterior segment to detect any breaks in the periphery, any treatable lesions in the periphery. So thank you very much for your kind attention, and thank you very much, Priya.
Thank you, Dr. Partha, for these videos. They were really great. Meanwhile, I would invite Dr. Lalit Verma to please be on the next presenter. There were great teaching points, sir, in your video. The way you do the posterior rexes, etc. It's very important. And I think one of the most important things for a newcomer who is venturing into doing a posterior rexes is, you try to have as much closed incision as possible, and then you try to venture inside and try to do a posterior rexes. Converting a rent into a rexes, it has got so many advantages that you probably would not even appreciate it, but actually it's really great to do that, first thing. Secondly, I think avoid doing all the swiping movements when you have a vitreous coming up, so with your forceps or whatever, with the rod or whatever you have, so, and then go ahead with a vitrectomy and clearing up everything. And as Dr. Partha brilliantly showed, that you can also put a one piece intraocular lens into the bag, probably if you have good space inside, and you can place the haptics inside, because you really do not want those haptics into the sulcus and rubbing and causing problems later on. So I think they were really very nice. Thank you so much for being with us.
This, the last two videos that I showed cannot be done for every case by everybody. If you are confident that you can do it, please try. If you are confident that there is space between the ruptured capsule and the anterior capsule, then only to try. Because at times it's not possible, the vitreous has come in between and it is sticky, so it is not opening up. In such cases, best not to try. Thank you very much.
Thank you so much. So we learned what to do and how to go ahead with, but I think during any intraocular maneuver, it is also very important to know what not to do. And I think Dr. Lalit Verma, he's going to highlight on all the aspects which vitreoretinal surgeon would not want an anterior segment surgeon to do when you have a complication.
Good morning. See, all of you are excellent cataract surgeons, and I just when I walked in, Ritika's videos and Partha's videos were great, and there's a lot of learning from all these videos. And at the outset, I would thank Priya Narang for conducting this course year after year, and this is a very, very popular course, and based on just popularity, she gains this entrance into every AIOS. Congratulations, Priya, for all this.
Thank you, sir, so much.
You see, PCR does happen. Anybody who operates, especially in the initial few cases, will happen. Issue is not that. You see, Partha was talking about prayers and all. We start praying if by chance it happens. Yes. Issue is not PCR, because it will happen and it will jeopardize, it will spoil your mood during surgery. Surgery will get prolonged. Patient on the table will keep asking questions. Dr. Saab, what is happening? You told 5-10 minutes, now it is taking 15-20 minutes. And in the operation theatre, there is a chaos. Vitrectomy machine lagao, ye leke aao, all these things do happen. And patient, believe me, comes to know that there is something wrong which has happened, which patient may not understand, but as a doctor, you have to do your best at that time. And howsoever cool you may maintain, there will, because I am an odd man out, I am not a cataract surgeon, I am a retina surgeon. So we get cases which have been spoiled or maybe mismanaged or have retinal issues because of PCR. Believe me, PCR, one small happening, if you don't manage the way Partho has told you, patient can develop GRTs, patient can develop CMEs, improper recovery of vision, corneal haze, everything. So it's easier said than done, maintain your cool and wo hota nahi hai. Issue is how it is best managed in the best interest of the patient. So I'll just show you a couple of videos only. So one thing which I don't like about any surgeon, whether it is anterior segment, posterior segment, to handle vitreous from the anterior segment. Because howsoever good you may be, howsoever attention you may be paying to fluidics, corneal endothelium is getting compromised. And the adequacy of vitreous removal cannot be there. The third thing is, there is always a scope for enlargement of the rent. So this is one very nice, good surgeon doing vitrectomy. You see, but this is a blind kind of procedure. You are not seeing what you are doing. Believe me, when other videos we watch, so you take the cutter at around 800 or 1200 speed and keep doing, because vitreous is a clear gel. It is not visible. Sometimes you may see one odd fibril, you say, okay, I have done the vitrectomy and lens has been put. But believe me, this eye which I am showing here, ultimately developed a detachment. But surgeon said, oh, maine to kar diya, vitreous vitrectomy kar diya, I did a very good vitrectomy. So blind vitrectomy, vitreous surgery, any surgery in fact, you cannot do a good job if you don't see. So here is a patient which I think everybody has stressed. So this surgery also has had vitreous loss. But here you are seeing, because you have put a tricot. Tricot has the property of getting adsorbed onto the vitreous and making the vitreous fibrils more clearly visible. So this gentleman I would appreciate more, rather than the previous surgery doing a blind kind of vitrectomy and satisfying yourself that I have done the vitrectomy. So here, believe me, this patient will be less prone for issues. Although still I am not very happy because it is done from the anterior segment. And no posterior segment surgeon would wish that vitrectomy should be done from the anterior segment. So, if you have a VR support, you see surgeons may have different kind of setups. If you have a VR support, my request would be to call him and let him do the job, because he does that job more often. Whatever you do that more often, and you have perfection in that. If you don't have any VR surgeon at hand, what should be done is what was shown in that video, that trichrotic vitrectomy. And how do you know it is adequate? One indicator could be that it's at the end of it nice round pupil. If the pupil is not round, that means vitrectomy is not proper at all. I do not advocate blind counter vitrectomy. I do not advocate a cutter which has not been used for a very long time. So preferably you should have a good cutter, or good cutter means maybe a fresh cutter, and handheld infusion with slow flow, and try to leave as much posterior capsule or rexus margin as possible so that lens can be put. You can insert a sulcus fixated lens, and what has been shown. And very important, which Parthos stressed again and again, is follow-up. Believe me, this eye is not the same as it would have been without the PCR. So this eye is lifelong prone for some issues. So in the event of crisis, respect the vitreous, because this is, you have to remember, if not the vitreous surgeon, but respect the vitreous.
Okay.
And if you want to believe me, these 5 photographs I show here, this is a giant tear, this is a reg RD, this cornea is getting compromised, this lady already had RK done before, and this is again a PVR. So these 5 examples I have taken from our library, just to show that if you do vitrectomy as I showed in the first video, all these things happen. And believe me, in the first go you may be very happy that you have done a good job, but follow-up, long follow-up, couple of months back, anybody can land up in this situation. And the other thing is, never, the upper right video is showing, never do this. Do not insert this monster-like instruments like inside the eye, vectis, and don't attempt this jhadu wala kaam that you do a sweep of the vitreous. You see how vectis is going inside, and this, believe me, this patient is number 1 here, giant tear. So here your surgeon is attempting to pull this nucleus. You see, this is again disaster, because vitreous is coming along with it. So don't do this. If at all, even if it falls, does not matter. There are, frags available, we can easily retrieve, and patient will have good vision lifelong. So this, see how much struggle is there. You see the margin of the pupil, pay attention to the margin of pupil, what is going on. So this should be resisted. 2 things, one is do not try to pull the vitreous, second, do not insert monster like instruments inside the eye, and do not do this sweeping movement of the vitreous like this. So therefore I said, please respect the vitreous. And why chromovitrectomy? Because clear vitreous as a cell is difficult to see, and vitrectomy cannot be blind, and you need to see what you are cutting, then only you do a good job. And as I said, transference makes the job easier, and preferably it should be done in a smaller pupil, because that is the best visualization which happens. This facilitates a precise job, complete job. I will not say eliminates everything, but reduces the chances of complication. So this is one video from our center site, where you see, this is a, I'll take one last video only. You see how much this anterior segment surgeon is struggling to do a vitrectomy, and how much cornea is getting distorted here. And there is a big PCR here, and how much vitreous is an attraction. Partha said it's vitreous base which is getting pulled up. Nobody is seeing the base at this moment at all. What you are doing is you are doing a blind kind of vitrectomy. And if you keep doing vitrectomy from the anterior segment, believe me, possibility, as I said, the third possibility is that you can enlarge this PCR. This was one animation borrowed from Dr. Vasavada's YouTube actually. I copied from there only. So this is red color is the vitreous. So if you do from behind, this vitreous is going back, and you see the PCR is reasonably stable. You compare this with the struggle of anterior segment surgeon where he is pulling. Now this red color vitreous is getting pulled up, because the vitrectomy is being done from the anterior route, and you see what has happened to the PCR. not only jagged margins, it has enlarged also. So don't try to do this. So this is one video from our library, that here this patient had suspicion of PCR, so we already put one cannula. Like Amar keeps telling every time, every surgeon should know how to insert a cannula. You see, whether in the anterior segment, or I would prefer a posterior segment, and he has shown very good videos, Amar Agarwal, which are very, very educative, that every surgeon should know this art of putting this trocar cannula. And once the anterior segment surgeon could not do this aspiration of the cortical matter, it was a soft kind of nucleus, because the vitreous was admixed with the cortical matter, and he was pulling more of vitreous than of lenticular matter, and therefore this was not coming out. So then he called the anterior retina surgeon, and he made these ports. And what I wanted to show here was the same thing which I showed in that video where red vitreous I had shown. Now it is being done from the posterior segment. Cornea is getting respected. Corneal endothelial loss will get reduced, and you are cutting and aspirating and cutting from behind, and you see how much easily this cortical matter will come out with minimal or no damage to this, and you will still insert an IOL. So you should strike where the enemy is, and then this IOL has been placed, and patient has good vision. So take home message is, in the unfortunate event of rent, if you do it from the limbal route, these three things could happen: residual vitreous, traction, extension of rent. Sorry. And to avoid all these complications, preferably do from behind. Thank you so much for your kind attention.
Thank you so much, Dr. Lalit Verma. There were great points into what he said, and the way he began with that, there should be no commotion in the OR when you have a posterior rupture. Actually, in my setup, whenever I am doing a surgery, and if there is a PCR coming up, when I utter the word vitrectomy, give me the vitrectomy probe, so the entire OT goes silent. Then starts the sign language. So then we talk only in sign language during the entire procedure, because it prevents at least the patient from getting panicky. Otherwise the patient starts getting restless that what is going on around. Anyway, but the way Dr. Lalit, he highlighted how to handle the vitreous and everything, it was really great. Have a triamcinolone during vitrectomy, and definitely the posterior route is definitely better than the anterior route. But then if anybody is not doing a posterior vitrectomy, at least do an anterior vitrectomy, at least clear the pupillary area, do something, because you cannot leave the vitreous as it is into the anterior chamber. If you have to compare, posterior is the best, but if you do not, for some reason, if you are not doing it, at least do an anterior vitrectomy and clear up the things at that point of time. And if you even have a major complication, then always you should have one or two VR friends whom you can refer your complications whenever they do happen. So I think we go ahead with the dynamic lady, Dr. Chitra Ramamurthy. So let us see what she is going to show us today, some of the misadventures.
A very good morning to one and all of you, and my very, very, very special thanks to Priya Narang for including me in this prestigious course of hers. I'm not going to be showing anything dramatic, something very simple, something very day-to-day with which each of us are going to be connected with, and which is definitely would be of practical relevance to us. Now this is obviously a very straightforward, simple case, well-dilated pupil, a nice round rhexis. There is that one area of suspicion. I do a good hydro because I don't think it's a polar cataract, rotated, and then I'm not able to get that first purchase, so I decided to do a stop and chop. There's that central clear area is there. It's not PCR, I'm pretty sure. And then I eat up the first nucleus. The followability is good, so again no PCR. I'm rotating the nucleus, again it's easy, but then see, there is a PCR sitting there. There's some vitreous traction, so I remove the phaco probe, inject viscode to plug the vitreous from coming forward. Some of it is already there, but I feel like taking off the tiny bits of epinucleus, then do a good vitrectomy. And then the ease with which I'm able to remove the cortex is a clear indicator that the vitrectomy is good. Of course, tricort is an ideal situation. There is a horizontal wraparound PCR, but there is enough PC support up and below. So with great confidence, a 3-piece IOL is injected into the bag. So well, it's centered, everything is all right. and then I start removing the viscoelastic in front and behind with absolute jubilance and absolutely confident that I've dealt with this. The cornea is clear. But look, the haptic is sinking, and the whole nucleus is sort of going into the vitreous and the lens, and then it's all becomes jugglery, and I have to get my piece up. Somehow manage to get my haptic onto the sulcus and take a heavy, relaxed breath. So the learning in this case was, if you have a PCR, you should be in a position to convert it into a PCC before you place the IOL in the bag. And even if you have converted it into a PCC, it's best to inject a single piece IOL very gently and slowly unfold it, because the PCC could also rip, and the 3-piece IOLs have a forceful injection which could land you in trouble and rip the PC. Now, this was a polar cataract with riders, and any polar cataract you should operate thinking that you're working on an open capsule. So then the first thing is you create a nice round rectus, because you believe that this rexus support is where the IOL is going to probably sit. So that's done. The next important question is, you don't want your bag to collapse. You do not want the hydrostatic keep fluctuating, because the posterior capsule is weak. It could give way, it could dehisce. So very gently, I create my first trench, very gently, and then keep injecting viscoelastic, because I don't want my bag to shrink or collapse. I want the bag to be distended. And till the contents are there, you're fairly safe. The bag is distended. And a very gentle phacoemulsification, keeping within the pupillary plane. And then the epinucleus has lost that endonucleus, and it just gets folded up and it comes. So I've done everything by the textbook, but then there you see a PCR, but this was probably a pre-existing PCR. I do not remove my phacoprobe, inject viscoelastic to put the vitreous behind, and then without needing the vitrectomy, the ease with which I'm able to tease out the cortex gently is an indicator that the vitreous has not come forward. I just keep going back and injecting viscoelastic on and off to push any possible vitreous which is trying to herniate forward, but it has not herniated forward. And then I remove the entire cortex. And now what am I going to do? Inject viscoelastic in front of the rexus, fill up that space, balloon up that space between the iris and the rexus, enlarge the incision, and very gently insert the 3-piece IOL, position the haptics on the sulcus, and then create a optic capture and remove all the viscoelastic and get out of the situation. A very simple case. The phacoemulsification is nearly done, and there the small rip of PCR you can see. I keep my phacoprobe in. I don't want the AC to shallow and the vitreous to come forward. I go in through my side port and then inject viscoelastic to push back any chance of vitreous coming forward, and then slowly I would remove my phacoprobe. Now what am I doing? I'm injecting a single piece IOL very gently into the bag. Believe me, even that stretching of the haptic should not be allowed. Rotation of the IOL should not be allowed. You should very gently, with the IOL sitting right where it is, gently tuck in the haptics into the bag. The cortex is still there. But what has happened here? Dr. Amar Agrawal is sitting right there. The IOL here is acting like a scaffold. It is keeping the vitreous behind, preventing it from herniating. And then, with absolute comfort and ease, I remove all the cortex, clear it up, and then I have a clean case. Well done. Now this is another situation. The surgery, well dilated pupil, surgery was going on quite comfortably. And then suddenly something happens. A temporary shallowing of AC caught the PC, and then the nucleus was somewhere subincisionally. But the vitreous had not come forward, so I go in through the side port, and with the second instrument, somehow managed to get that piece right up into the anterior chamber, inject viscoelastic so that I push the nucleus up towards the endothelium, and now I'm going to enlarge the incision. And the plan of action is, as it was in the earlier case, now I'm going to place a 3-piece IOL. Now, if the vitreous is there, you could leave the haptic of the IOL on the iris, or if you feel there's not so much vitreous disturbance, you could position the haptic in the sulcus itself, where it is to be. And now the nucleus is well protected by the IOL sitting below, and you're able to do your phacoemulsification with great ease. Yes, it's a supracapsular phacoemulsification. You need to inject viscoelastic, then go and do a vitrectomy behind the IOL. You want to get all the vitreous, all the debris out, go in front, and again, see there is that vitreous stand, do a good vitrectomy, inject tricord, because that's going to clearly delineate the fibers, and then whatever residual is there, you cut and you get out of that situation. Now this is a case, the patient came to us like this. with a bag torn and the single piece IOL in the bag. So what do? Do I just gently, there is vitreous there, so do I just gently nudge it and position it there and send the patient off, or leave it like that? The patient is visually disturbed. So first, I do a good vitrectomy behind the IOL, in front of the IOL, and now the responsibility is there. I need to take care of this patient. So I am going to nudge this haptic out of the bag, and as you can see, it is coming out, positioning it out. And once I bring it out, I just enlarge the incision, because I realize that this has no place with that kind of a posterior capsular support. So I bisect it halfway and I pull the IOL out, and then I would still, after having had done a fair amount of vitrectomy, I check whether the IOL has been removed in toto, and then I go in and inject my 3-piece IOL onto the sulcus, do early residual vitrectomy, and get myself out of the case. Now this is the last video I have to show. The patient comes back the next day with a small endonucleus fragment behind the IOL. A PCR had been there, but the IOL had been placed in the bag. So then I inject tricot, go in, place in a trocar in the pars plana, and do a vitrectomy from behind. By doing vitrectomy from behind, there's no gush of vitreous coming forward, because you're cutting vitreous close to its home. There's less vitreous traction. There's less chance of the PC increasing in size, because there is no gush of vitreous which is going to come forward. And then you have done a fair amount of clearing. You could leave the IOL there, which is well centered and seated well, and get yourself out of the situation. What I've said is nothing very different from what the previous speaker said, but different examples. This you may not realize now, but when you go back to a theater and you face a similar situation, a very simple moment, you remember what had happened, and you find that the challenge of each case teaches us to a greater learning and a better surgeon each time. Thank you.
Thank you, Dr. Chitra. I would just like to ask from the audience, how many of you are doing vitrectomy from the pars plana? If you have a rupture, I can see you are a first year, so you don't have to raise your hand. So, okay. So I think one of the, I would be really happy if few people out of here would go back and try to involve doing a pars plana vitrectomy in their setup. You don't have to do much. You only have to learn how to place either a trocar, or you need to make an incision at 3 millimeters with an MVR. You can take some tips from your posterior segment surgeons. It's not very difficult to do that. So I think that's that would be one of the great outcome of this instruction course. If people start going back and start doing at least a pars plana vitrectomy, you only have to venture into the pupillary zone and into the anterior chamber. Just clear off that much vitreous. If you have much more problem beyond it, that's not meant for anterior segment surgeons. That patient has to be referred. But doing a very good amount of vitrectomy, I think half of the problem gets solved. You know, all the post-operative complications that usually happen, like CME and everything is being taken care of. So I think that would be really fruitful if people would go back and do that, and never use scissors for doing vitrectomy. That has to be abandoned. It should not be done, actually, and no placing of wicks and everything on the corneal incision and trying to roll that cotton and trying to cut with the scissors. All this, I think it should be abandoned totally. Thank you, Dr. Chitra, so much for being here with us. And we go on to Dr. Ajay Paul, another dynamic surgeon, and he's going to talk to us about again about anterior vitrectomies and how to do an optic capture.
Thank you, Priya. I think it's wonderful to be in your course year after year. And since, as you said, posterior vitrectomy is the order of the day, if you have a lot of vitreous gushing into anterior chamber, but since my topic is anterior vitrectomy and IOL capture, I'll limit myself to that. Now, this is a case of a high hypermetro, basically a high hyper, who had a trap plus phaco was planned for. You can see I'm starting this. I mean, this is a shallow chamber. I am starting with the IOP of 50. I'm feeling that the chamber is becoming shallower as time goes, because I have kept a vacuum quite high, around 600, and the aspiration. I have got my IOP higher. I've got it around 55, but still I'm feeling that, well, I'm not very happy with the dynamics. That is because there's an anterior chamber, and there I realize that I've caught the posterior capsule, and there is a small rent there. And as you can see, this is the moment when you have to be alert. How you go, as Partha said, take a small drip, and I mean, you cannot stop your surgery, but then definitely all your senses are alert, and I'm doing a bit of clearing of the lens matter, as my friend philosopher guy Dr. Amar has shown us the IOL scaffold in these sort of cases, and Priya, Dr. Chitra also showed. Now this is the lens which I am dialing it, putting it over the sulcus, and since most of the I could create a differentiation between anterior and the posterior and take off, I have reduced my IOPC. Again, this important that when you do that, you don't want that lens. If you have a bigger opening, the whole lens might stick inside. So get your IOP down at that moment, and that's what I, in spite of from 55 got to 30. I've got almost all my, and then I'm doing the bimanual ISC. With one hand, I'm pushing the lens that is at the scaffold, and I'm taking out the cortex as much as possible as I'm going. See, the iris has already plucked my incision, and every time I come out, I'm putting the viscoelastic so that I don't lose that. I mean, I have realized that I have not got vitreous, but at the end of by the end of the surgery, as I'm trying to clean the cortex, I might have caught some vitreous strands as I continue that cleaning, and then there I clip the iris to the anterior, the lens to the anterior capsular margin, and there I've got a round, and I do a bit of anterior vitrectomy. And then the surest test, I just put a blob of air there to see that the air is well formed, and that is one of the good tests you can do instead of putting triamcinolone. This is the second case when I am doing my last case of bimanual IA. As you can see, as I'm trying to get those is there and that side, and there I realized that probably I have a rupture there, as you can see very well. You can see there, yes, there it is. Now this is not totally halfway as Partha has shown or Chitra has shown. See, this is the margin which is already everted there. So there can be, but this is a sign. Now earlier, if you have noticed that the margins were clear, here the margins are everted. So that's a sign that there is a little bit of vitreous popping out there. So I continue there. My option of putting, as you can see there, the vitreous is popping out there, but the anterior vitreous phase is okay. But since the margin is everted there, I'm not sure whether I should go in with a single piece lens within the bag or the sulcus. Now I thought it's better I put a bit of, as you can see, I'm trying to get that bag filled up. I can still see this is not halfway. I put a bit of my good friend Viscoat there, and then I just plug it there, and then I decide, well, let me put a lens in the sulcus, and the best possible that I think is the sensor lens, because it has got an anterior curved surface, and that helps in a long term. Now look at the way how the lens is put in. So it should be gradual. The pronation and supination of the hand should be right enough. At the same time, don't lose your anterior chamber at this position. If you try to dial it from the side port, and then there you have got, yes, the lens is now stuck in the anterior lens capsule, and there you have got it there the right way. I need not do a anterior vitrectomy there. I have checked it, and then put a best in these sort of cases, put a bit of pilocarpine and see the pupil comes down. And this is the next case. As you can see, this IOP, the rhexis is so important in all cases. That's why, in case you go one, other than giving you the shrink wrap effect, that central round rhexis 5.5 millimeter will definitely help you in keeping the lens. If you want to put it in the sulcus, so IOL capture can be done. See, this is where I caught it, by vacuum was too high, and there you can see this lens. And as I'm trying to put this a single piece hydrophobic lens. Now look at this. This is a single piece design. See, as I put it, the lens goes in, and I realize that I have got a rupture here. My capsule, by this haptic, has gone into the bag, and I have got a rupture here. And this is a peculiar design, or see the lens I'll be using, that's got two flange or wings by the side. Now this is a bit tougher than the normal, the Rayner that you get, hydrophilic lens. Now this is a bit tougher, and see that I put it there, and this is the position. I've got an almost oblique rupture there. This haptic is in the bag, and this haptic is still outside the bag in the sulcus. So there I put in viscoelastic from the side. Now I've kept it the way it is. The IOP is 60, just to keep the pressure down, and then little of viscoelastic both behind and in front of the lens, and then gradually tuck this in the bag there, and use these flanges. Bring these flanges in front of your anterior axis margin, so you have two haptics going into the bag and two flanges coming outside the bag over the anterior capsule margin, and there you have got it. See, that's it. And you have got a combination of lens in the bag and lens, part of the lens in the sulcus, the haptic in the sulcus. The the last case again, this second last case again, how to get your IOL capture, just push it there, you will have to get it in the oval shape. Now look at this, this is the oval anterior capsule. Once the two haptics are there, and this is the right way to get it, well round center and oval. And the last case, this was a traumatic, I know this is a history of trauma, a 8-year-old boy. As you can see, there's a history of trauma here. I don't know whether there's a posterior capsular rupture also, but this is how the patient came in. As you can see, here I go, it crosses that, and see there is a bit of fibrosis there. And then as I go forward and front, do a bit of, with the visco, I try to clear that, and this is in the fast forward phase, a little bit of hydro. And then as I go to my bimanual, since this was up there, I can see a big rupture there, and there I clear up as much as cortex from the periphery. Remember that this is a 6-month-old this penetrating injury, so I would expect that the posterior capsule, whichever was ruptured, is already fibrosed by the side. So in this sort of case, generally I would wait for some time till the fibrosis sets in. As I'm trying to clear up the cortex, I know I'm catching up some of the vitreous strands, so there I'm forming the bag, and then continue with the anterior vitrectomy, take out a little bit of whatever vitreous strands that are there. I have not used still the triamcinolone, but I try to increase that posterior opening also, and then put in the lens in the sulcus. As you can see, the lens, the way you have to put it, pronate it. See that at this point of time, the whole anterior chamber is well maintained, so that you don't lose the chamber on the whatever vitreous that might come forward. Once that is done, I've got captured the IOL in the anterior axis margin. Once that is done, I do put in a bit of triamcinolone, and then this is the triamcinolone, and then continue with the anterior vitrectomy, and see that the pupil comes down, whatever little strands that are there, I can see, and that's it. Thank you for your patient hearing. Thank you.
Thank you, sir, for some lovely illustrative videos. 2-3 key points that we must remember is we saw how the capsule got captured in the port. Remember, when you do capture the capsule, don't move the port around. You must be familiar with the reflux button. If you're using a new machine, the foot pedal yaws and gives you a reflux. So even if you've caught the capsule and you just don't pull on it, when you're suddenly jerking, you can obviously reposit the capsule back without a PC rent. Another thing you must be familiar is the vitrectomy settings. All of us must be familiar with what vitrectomy settings we use. We normally use the highest cut rate that is possible on the vitrectomy machine. The infusion has to be put into parallel to the plane of the iris, and your infusion is directed for the anterior chamber. But when you're doing vitrectomy, you have to go deeper. So vitrectomy is posterior directed, but infusion should not be posterior directed. You don't want to hydrate the vitreous. So any other comments or questions from anyone for the talk so far? We now be moving on to Dr. Priya Narang. She's an innovator and a surgeon par excellence, and she'd be showcasing some IOL implantation videos in complex and tricky situations when we're faced with the PCR.
Thank you so much. First of all, I would like to thank everybody for being here and being so patiently listening to all the speakers in this instruction course. Thank you so much. So I go ahead with my instruction course, and there will be lots of do's and don'ts going on at the same time, which I'll keep on speaking as the video moves forward. As you see in this case, this is a posterior polar cataract. It's a frank cataract. I think the video is not running here. Oh yes. So you go ahead, the routine things I'm not going to even talk about it, but I'll talk what is going on and what is not to be done and what is to be done. You go ahead with with filling up of the viscoelastic and you're doing an anterior rhexis. Anterior capsulorhexis is very important in these kind of cataracts because whenever you have a complication, you need something to place your intraocular lens on because you know that the posterior capsule is going to be affected in this case. It might be affected, but believe me, in many of the cases of posterior polar cataract, when they are handled properly, you know, you can just limit the size of the opening, that's the opening of the posterior capsule to as it is and not enlarging it to beyond a certain limit. Now when we go ahead, there's a rule, do not do a hydrodissection in these cases, a hydrodelineation, and try to lift this. Okay, now when you go ahead with the phacoemulsification, you need to be very patient while handling these cases, and sudden flipping of the central cortical material should be avoided when handling these cases. Now what you see here is the flipping has occurred and now it's all gone because the posterior capsule has enlarged because already there was a defect, and when the flipping movement comes in, it pulls the posterior capsule along with it. So this is how the posterior capsular opening, which could have been limited, it enlarges to its maximum size, and then probably if you you can have a drop. What you are seeing in this case, the fragment has gone down. So now coming up to this, I will just pause this video here. You have many options out here at this stage. If you have a posterior segment, a VR setup in your center, you go ahead with, you have somebody to take care of this thing. But if, I think Dr. Prashanthi can tell us what he would not like the anterior segment surgeons to do here. What you can do at that point is, you can go ahead with a vitrectomy. You do your role. If you are just an anterior segment surgeon, you go ahead, you do your vitrectomy, clear up the cortical material as much as possible. Do not fish into the vitreous cavity. That should be avoided when you have something like this going on. If you have cleared up the vitreous from your entire anterior segment and from the pupillary area, you can even place an intraocular lens. But there are surgeons, VR surgeons, who would not prefer you to put an intraocular lens. They would prefer to put it at a later stage, probably when the posterior, drop material has been handled. But if you have a VR setup at your place, you can go ahead with that. You clear up the drop, you clear up the nuclear material from the posterior segment and come up. Now coming up back to the point that suppose if we are all an anterior segment surgeons, what you would do in this case would be that you have an intact anterior capsule which is there for the intraocular lens fixation. So you are safe at this point. But in case if you have a break in the capsule, still you can place an intraocular lens. Probably you know how to place the haptics of the intraocular lens, where you are placing it. But if you have it running at some places, it's off-centered and it's not in a position to give a stable fixation or a placement of the intraocular lens, then what you need to do is you have to do a secondary IOL fixation. Now here, and you have to have a clear look of what is going on. You cannot just inject the intraocular lens and just keep on guessing where it is. If your pupil has come down, you need to dilate it. And especially in these cases, what I would personally prefer is an iris hook, because you know hooks are external devices which are fixed up and you can place them as you want rather than going with any of the rings, because they can slip and go back into the vitreous cavity. So the best thing to do in these cases is take up a 3-piece intraocular lens, place it in the sulcus. You can do an optic capture. Even if you do not do an optic capture, if you do it, it is the best thing to do. I'm not saying not to do it, but it should be done. But the point is, always have a 3-piece intraocular lens. There is one more situation in these cases. If you do not have a 3-piece lens in your setup at that point, what do you do? Because it does happen at times that you are not ready with it, but especially if this is a polar cataract, so you have to be ready with it. But otherwise also, you should have some set of 3-piece intraocular lens into your setup, you know, so that you can place them as and when needed, and especially in these kind of cases. So if you do not have it at that point, do not place a 1-piece intraocular lens. Now this is the common mistake that every surgeon does, an anterior segment surgeon, because they are afraid to go back and tell their patient, look, I have not put a lens. What you are supposed to do at that point is you can pause yourself, you can push your patient out, you can wait, you can order an intraocular lens, and I think in most of the cities you do get the delivery of the lens, and you can again take back the patient and place it, or maybe you can even wait in the OT till your lens is being delivered to you. So anyway, these are some of the practical points that I'm just mentioning. This is another case. You have a decentered 3-piece intraocular lens here. So now again, there are many ways to build the CAD. You have a decentered 3-piece IOL here. You have a posterior capsular opening also which is there. So some of the surgeons would go ahead and, you know, try to do capture again in this case. But in this case, if as you see in this area, there is also the after cataract, the sombering material has been deposited. So even if you try to place your intraocular lens here centrally, try to place it off, it will give a lot of astigmatism because the haptics are not going to be there on the same plane. They will be elevated on one side and depressed on the other side. So trying to take an advantage of an already placed 3-piece intraocular lens in the eye, you know, you do not have to enlarge it. So what I basically try to do in these cases is, you know, refixate this intraocular lens with a glued IOL procedure. The secondary IOL fixation procedure, which I always try to do in these cases. So what you see here is that, you know, the 2 flaps had been made already before. There is a fluid infusion going on in the eye. Fluid infusion is very important in these surgeries because you cannot do this under viscoelastics. Do not inject viscoelastic. Viscoelastic goes behind, it will give vitritis, and you are going to have postoperative problems with these cases. Now, specifically to this procedure is that you need a 3-piece IOL which was already there, so you can exploit that situation and go ahead with the fixation of the same thing. Always catch the tip of the haptic. Once you grasp the tip of the haptic, you just externalize the haptic by pulling it. You do not hold the haptic from anywhere except the tip, because, you know, if you hold it from mid-length or somewhere and you're trying to pull it out, you will create a kink in the haptic, and when you try to straighten that kink, it breaks. So anyway, after that, you might need to expand that intraocular lens. So these are some of the tricks of a glued IOL procedure. If anybody is following this procedure, they can go ahead with this. These days, the Yamane technique has also been adopted by many of the surgeons. So even if you are doing a Yamane, what you can do is you need to go ahead with threading of, you can again take advantage of this 3-piece intraocular lens which is already there inside the eye. Even if you are doing a Yamane, the only thing is that maybe these are the PMMA haptics and you need to create an appropriate kind of flange with that procedure. But this works really well. For the glued IOL procedure, it is always the tucking of the haptics which is important, because that's the intrascleral fixation. That is where, you know, the strength of the IOL fixation comes from. Again, I would say glue, it only prevents postoperative hypotony. It helps you to seal up the flaps, seal up the conjunctiva, and it prevents a hypotony. But when it comes to stabilization of the intraocular lens, it is the amount of haptic that you are tucking into the scleral pocket that is very important. So that has to be around at least 2 to 3 millimeters tucking of the haptic has to be there. So I would just run through things now because I'll just cover 2 or 3 videos. This is what you see is a 1-piece intraocular lens. Now this lens is dangling behind. So what we need to do in this case is you need to explant this intraocular lens, and in order to explant this intraocular lens, you need to create a scleral tunnel incision, or alternatively you can also do what Dr. Chitra did. She just cut up the intraocular lens and she pulled it out from a comparatively smaller incision, so even that can be done. Another thing what has happened in this case is probably the surgeon had placed this either in the bag or into the sulcus, whatever be, because you can also see the fibrotic capsular rim in almost about 270 degrees which is there, but anyway the intraocular lens has decentered, so you need to explant this and go ahead with that. So I'm just trying to showcase you here that this intraocular lens is now being lifted into the anterior chamber. You do a decent amount of vitrectomy behind the intraocular lens and then pull this intraocular lens, take up the sutures, prevent any vitreous that comes up into the corneal section, into the corneal tunnel, and then you go ahead with the fixation of this procedure. Haptic externalization is being done here. You catch always the tip of the haptic and you're externalizing, and you're almost done with this, because after this you'll just do the tucking and you will suture up the scleral wound. So this is another thing, many of the surgeons, they keep on doing this. Have a look at this. This is a 1-piece intraocular lens which is placed in the anterior chamber. Never do that. It's a PMMA kind of IOL. It's definitely going to give problems to the patient. So you are trying to dial this intraocular lens. This intraocular lens has to be removed from where it is, and it is being, we're trying to just manipulate this and trying to remove this intraocular lens. Probably initially we try to make an attempt to refixate this intraocular lens. Actually, for a glued IOL procedure, we always recommend a 3-piece intraocular lens and never a 1-piece IOL. It's only just it depends upon the expertise that you probably have of handling the haptics, that you can pull and go ahead with handling this, but then I would not recommend anybody who has just ventured into doing a glued oil procedures to go ahead with a one-piece intraocular lens. The simple thing would be just make an incision, enlarge, and remove this. So I think I'll just go through one or two tips here. This is an intraoperative PCR. So the first thing that you do is seal the corneal incision because you don't want any vitreous coming up. Put a fluid infusion inside the eye, again very important. Do not just keep on injecting viscoelastics and trying to handle everything. Fluid infusion in the eye, it prevents half of your problems which you are going to face in the post-operative period. So either if you have a trocar, it is the best thing because the fluid comes from behind and it helps to maintain the globe. If you are using an anterior chamber maintainer, again you have to be very specific of how you are placing an anterior chamber maintainer because the fluid should not push the fragments which are there into the anterior chamber. It should not push into the posterior chamber. So that is one thing which you need to be very careful about. You go ahead. Now this is a limbal vitrectomy. Actually, you should ideally be doing a pars plana vitrectomy, but you also need to clear up the things which are there. So you just do a limited amount of this, but you know that there is the fragment in the posterior segment. So anyway, it needs to be cleared up. So you go ahead. I mean, I'm just running through this. You make the flaps. You go ahead, make a sclerotomy for haptic externalization, which has to be made 180 degrees opposite to each other. Now the VR part is being taken care of. You remove the lenticular fragments behind. Go ahead with a fresh 3-piece intraocular lens, and you externalize the haptics. This is the leading haptic which has been externalized. Now you flex the trailing haptic again back inside the eye, and you flex that. Try to go, this is the no assistant technique. You go ahead and hold the trailing haptic, the tip, and then again you externalize this haptic. So you're done with this procedure almost, and then you seal up the corneal incision, the flaps, you do the tucking and everything. So I think with this, I think I would like to end up because even though I have lots of things to say, but in want of time, if anybody is interested, you can just go through this book, which I recently published, and it is available with theme online on what is about the optimizing, how do you optimize the suboptimal results following a cataract surgery. And we recently came up with a video atlas for segment repair and reconstruction with theme. It is available on their website. Thank you so much.
Thank you, Dr. Priya. Any questions for Dr. Priya? Any questions for the glue dial technique? We have Dr. Amar Agarwal and Dr. Priya, two pioneers for that. Do we have Dr. Hisham with us? Dr. Hisham, he is our keynote speaker.
So I think we would like to invite audience participation here. I would like the audience to come up with at least few of the questions because I don't think everything seems to be quite clear always. So even if you have any minor question or anything major, whatever you want to ask, anything small or big, please do come up and please do have it because we have distinguished speakers all around here and faculty to help. Yes, yes, please, please.
A wonderful course. Priya, I always come and attend this because I learn a lot from you people. Ajay is gone, I think. Ajay is here. Ajay, you know your iris coming out, your IOP was 60. Should have brought it down to 40. Iris would not have come out so much because if the pressure inside the eye is 60 and there is an opening, your iris is going to come out. There's just one comment. You need to do that. And Priya, you asked a question that when posterior segment and when anti-segment surgeons should draw a line.
Yes.
I think the best thing anti-segment surgeons is that there are plenty of posterior segment surgeons available. Make a friendly call with them. As soon as you have a problem, give them a call. Your OT should be equipped to handle posterior segment surgeries. That's one thing. Second thing is how long you should handle. As soon as you stop seeing a segment of nucleus which is dropped, your job is done. Just
Absolutely.
clean the anterior segment, suture, and send the patient to posterior. If it can be done in your own setup, that's the best thing. If you have a setup, the surgeon will come in half an hour's time, and you can definitely wait, because I've seen this even in a higher center like LV Prasad. The anterior segment surgeon I was watching, he dropped the nucleus, he stopped the surgery. And after 2 hours, the posterior segment surgeon came and finished the surgery.
Yes.
So it is a possibility, because as soon as your nucleus more than half is behind, you do need a fragmentome. And you do need to enlarge the incision and everything. So these are a couple of points I would like to say.
Yes, absolutely. And I would also like to ask you, Dr. Prashant, that like you have a clinical situation where you have a rupture and you have a drop. It is there. So would you like the anterior segment surgeon to clean up the anterior segment, place the intraocular lens if there is a good sulcus or whatever, and send it to you, or would you prefer that the surgeon should not do anything?
Perfect. Priya, it depends upon how much of the cortex is left behind.
Yes.
If there is a lot of cortex and you're going to manipulate and make corneal decompensation, no, don't do it. But at least whatever is in the anterior chamber, remove that cortex if it doesn't have a vitreous mix. As soon as there's a vitreous mix, unless you're equipped to do vitrectomies, do not touch it. You
Correct.
can put in a viscoelastic in the anterior chamber so that the cortex do not touch the endothelium, because as long as the cortex will keep touching with all the fluid movements, it will damage the endothelium. So at that stage, I think it's better to bring in the posterior segment.
Yes, and one more thing that I would like to tell everybody. Suppose if you do not have a VR setup and you have to send your patient to your VR surgeon at his clinic, one more important point is take as much amount of corneal sutures that you would need to close the incision. Do not send the patient even if you have made a 2.2 millimeters corneal tunnel and you feel that, oh, I mean, it's absolutely closed chamber. No. You have to take, even for a 2.2 millimeters tunnel, at least take 2 sutures and seal and make it wound tight. Even if you have a side port, take 1 suture. Make it as tight as possible and send the patient. There should be no leaking of vitreous from either the paracentesis or from the corneal incision. No matter how confident you are that there is no vitreous in my section, still do take it, because you don't know if the block goes off and the patient starts blinking and all that. That movement, it should be restricted. So I think that is one of the most important things. A closed wound should be there when you are sending your case to a VR surgeon. And remaining thing, I think Dr. Prashant, he said very well to us. We have Dr. Ritika, she is going to show us one video how to place a trocar. Please do have a look at it.
So we're talking about pars plana vitrectomy. It's very easy to do a pars plana vitrectomy with the present instrumentation. I'll just be showcasing how to put in a trocar cannula system into the eye, which makes the anterior segment surgeon actually deliver the outcome.
23 gauge micro
Can you
incision
just increase the volume?
system forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of 3 23 gauge trocar cannulas, an infusion pipe, and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar, threaded over which is a round-bodied cannula. In a phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly, and the trocar cannula is inserted in a 2-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
So with this technique, when you have a trocar and you're putting in the vitrectomy, you're not close to the retinal surface because you're going in through a round-bodied cannula. right? So when you're introducing the vitrectomy for pars plana vitrectomy, you're not going to touch the retinal surface. Entry-exit retinal tears are very less common now. So if with the trocar cannula system, an anterior segment surgeon can easily do a pars plana vitrectomy.
That was a great video. One more tip, Dr. Prashant, I would like to tell you, being a VR surgeon, when you are putting the trocar, do not directly after that start the infusion, right? Do you check the port of the infusion? Absolutely. Yes, that's a very, very important point. Yes, because you need to see the infusion which you are going to start. You need to see that whether it is placed correctly from inside. You know, it is there. Otherwise, you can have much more complications. So I think that was really great, Dr. Ritika. Thank you so much for showing that. Any further questions? So I think it was we are almost done with this. So I would like to thank each one of you for being here, and all my co-instructors, Dr. Ritika, Dr. Chitra, Dr. Ajay Paul, Dr. Partha, Dr. Lalit. Thank you all so much, and everybody for being here. Thank you so much.